Thanks, Valerie. As Valerie said, that I'm Gianna. I'm a first-year fellow at the Georgia Department of Public Health, and today I'll be presenting on an outbreak investigation that I've assisted with titled Outbreak of Mycobacterium abscessus infection among patients of the Pediatric Dentistry Practice, Georgia 2015. So, the learning objectives of this presentation are 1, to describe the demographics, symptoms, and treatment of affected patients, 2, to understand the current guidelines for dental water quality and the public health impact of poor dental water quality, and 3, to discuss prevention and intervention methods to reduce transmission of potentially pathogenic bacteria through water used for dental procedures. On September 13, 2015, the Georgia Department of Public Health, DPH, was notified by Hospital A of a cluster of pediatric Mycobacterium abscessus infections. Hospital A had provided care for 9 children who developed a presumptive or confirmed M. abscessus infection after having a dental procedure at Practice B, which was later determined to be a pulpotomy. And so we, DPH, initiated an investigation to identify the outbreak source and recommend prevention and control measures. Through our investigation, we discovered that all of the patients, with the exception of 1, had the pulpotomy performed at Practice B. This practice is part of a pediatric dentistry chain, and it has 20 locations in the Atlanta area, and is a very large provider for Medicaid patients south of Atlanta. A little bit about Mycobacterium abscessus, or M. abscessus. It is a rapidly growing, multi-drug resistant, non-tuberculous mycobacteria that's found ubiquitously in the environment in water, soil, and dust. It commonly causes skin and soft tissue infection and can cause disease in multiple organs. You can see this picture on the right is from an outbreak caused by M. abscessus following acupuncture. And this cartoon shows the process leading to biofilm formation, in which the bacteria can adhere and multiply on the inner surface of tubing. NTM species, they display tolerance to commonly used disinfectants and are frequently found in the plumbing of healthcare facilities and water distribution systems, and improperly maintained dental unit water lines can then become contaminated with these microorganisms, which includes NTM, and form a biofilm where it replicates within the water line. This list is not exhaustive, but highlights some of the past outbreaks of M. abscessus. 2 of these outbreaks resulted from contaminated water used to dilute products. One of them occurred at allergy injection sites where water was used to dilute a topical preparation, and the other resulted in skin and soft tissue infections among acupuncture patients after a solution used to disinfect the physical therapy devices became contaminated. More recently, there was an outbreak that occurred among lung transplant patients, and the source was traced to new building construction and tainted water supply. So while previous outbreaks have been associated with cosmetic procedures and nosocomial transmission in a variety of settings, this outbreak is unique in that it represents the first known case of transmission in a dental setting. Cases were defined as illness compatible with M. abscessus infection among children with an illness onset date on or after January 1st, 2014. Probable cases had physician-diagnosed illness consistent with M. abscessus infection, which included facial or cervical swelling, commonly with lymphadenopathy, and appropriate histopathology, such as granulomatous inflammation. Confirmed cases were those in which M. abscessus was isolated by laboratory culture. Our active case-finding efforts included contacting all patients with a recent history of pulpotomy seen at Practice B, notifying area pediatricians and dentists of the outbreak, and reviewing Hospital A pathology reports and M. abscessus positive cultures since January 1st, 2014. DPH also sent notifications through professional organizations and internal networks that alerted providers in the Atlanta metropolitan area of the cluster and asked that those with a history of pulpotomy in the past 6 months be reported for follow-up. And we visited Practice B on September 22nd, 2015, to evaluate the infection control and prevention practices and to view a mock pulpotomy demonstration. We performed a walkthrough of the facility to observe their sterilization techniques, storage of supplies, and their cleaning procedures. During this time, it was noted that Practice B used tap water for pulpotomies without recommended water quality monitoring or bleaching of water lines at the end of each day per manufacturer guidelines. And at this practice, a drill with water, specifically tap water, is used to remove the infected portion of the vital pulp. Afterwards, the tooth is placed with a crown. A pulpotomy procedure specifically involves the removal of cavity and partial removal of nerve in a primary tooth with extensive cavities. And it's sometimes referred to informally as a baby root canal. It's only used on baby teeth in an attempt to preserve the tooth and supporting tissues and to maintain space for adult teeth. And some people wonder what the benefit of having a pulpotomy is other than aesthetic when the tooth could just be extracted. And the answer is that keeping this primary tooth healthy promotes the proper growth of future permanent teeth. So if a pulpotomy fails, then an extraction of the tooth will be recommended. As of today, we have identified 21 children meeting our case definition, with our most recent case actually being reported on January 25th, 2016. And with the exception of one, all of the cases had the pulpotomy performed at Practice B. The patient demographics presented here contain information on 20 patients we currently have complete medical and dental records for. So it's not including the most recent case because we don't have complete records for that person yet. We definitely hope that no additional cases arise. However, it is important to note that case finding is ongoing. The median age of case patients to date at date of onset was 7 years with a range of 3 to 11 years, and 11 were male. 2 had a past medical history of asthma, and none were immunocompromised. All of the case patients had at least one pulpotomy performed in the year prior to illness onset. 85% reported pain, 70% had osteomyelitis, 60% reported facial swelling, 50% had lymphadenopathy, and 36% had pulmonary nodules. All case patients had at least one hospitalization, and many of them were seen by various providers, like a dentist, primary care physician, emergency room, etc., before they were actually diagnosed. Looking at diagnostic tools, 85% had an XCT, 55% had a chest X-ray, 25% had an ultrasound, and 5% had an MRI. All case patients required some type of surgical intervention. 17 required excision and/or biopsy, and 7 had incision and drainage. 10 had a PICC or central line placed for long-term intravenous therapy that was to be given at home by their parents. 11 case patients had cultures positive for acid bacillus, and 7 had positive acid bacillus stains. Most of the culture-confirmed patient isolates were found to be resistant to multiple antimicrobials, which led to complex therapy that often included intravenous antibiotics with potential complications. An example of this is the antibiotic amikacin. So in addition to the need for a central line, serious side effects of this drug include renal failure and ototoxicity, which can cause irreversible hearing loss. Some of the patients needed complete surgical removal of the infection, and subsequently, several have partial facial nerve paralysis of unknown long-term significance. The ultimate clinical outcomes are unknown, as 16 of these patients are still undergoing follow-up. We also looked at the dentist and technician that performed each case patient pulpotomy just to see if there were any trends. And we noted that Assistant I treated about half of the affected patients. Practice B hypothesized that some physicians have a preference to work with a specific assistant on certain procedures, and Assistant I was reportedly very experienced and often helped with more complicated procedures, such as a pulpotomy or extraction. And so we concluded that no underlying condition or specific dental provider appeared to explain these infections. Here is a standard epi curve of the outbreak. Of the 20 cases identified that we have complete and medical dental records for, 11 are culture confirmed and 9 are probable. The earliest case had an onset date in March 2014. The second case's onset was in June 2014, and then the remainder had onset dates during March to November of 2015. The 9 original case patients were identified by Hospital A, and the remaining 11 were identified through Hospital A as new patients presented or through active case finding, as previously discussed. So with this data, we are able to calculate an attack rate, which is the proportion of cases that develop disease out of the total number of persons at risk in a population over a specified period of time. And for this calculation, I'm using data from Practice B exclusively, so I'm excluding the single case that was not seen at this location. And this makes our numerator 20. Our case definition time frame extends from January 2014 to September 22nd, 2015, when Practice B temporarily closed. So during this time frame, a total of 1,386 pulpotomies were performed, which is our denominator. And based on this, the estimated attack rate was approximately 1.4%. This graph shows kind of a comparison of the month of suspect pulpotomy, which is in blue, and the month of illness onset, which is in green. And you can see how there's two distinct curves that are formed with the number of suspect pulpotomies peaking around May 2015. The suspect pulpotomy dates range from October 2013 to September 2015, while the dates of illness onset range from March 2014 to November 2015. And then this last chart shows two events. First, the time from pulpotomy to illness or symptom onset, which is also known as the incubation period, and that's in green. And second, the time from illness onset to hospital referral in blue. The median incubation time was 58 days, with a highly variable range of 18 to 164 days. The median time between the date of symptom onset and the date of referral to Hospital A was 37.5 days, with a range of 7 to 99 days. And so on September 24th, 2015, water samples were collected for microbiologic analysis, and patient and water sample isolates were then sent to CDC for molecular characterization by pulsed field gel electrophoresis, or PSGE. And this picture on the top left is of myself collecting water samples from one of the 7 dental stations. And directly below that is a picture of one of the stations where you can see the various dental handpieces. And this last picture shows what grew from the samples we submitted. So before I present the actual laboratory results, I wanted to review the current recommendations for dental water quality. 2003 CDC recommendations state that water used in non-surgical dental procedures, which includes pulpotomies, meet EPA regulatory standards for drinking water, which is less than or equal to 500 colony-forming units of heterotrophic bacteria per milliliter of water. So keeping this recommendation in mind, here you can see the results reported by CDC for the water samples collected. All of the viable counts exceeded the CDC's recommendation, ranging from 31,000 up to 190,000, which is highlighted, and it had an average of 91,000 colony-forming units per milliliter. Additionally, all of the water samples cultured M. abscessus, and then were later found to match the patient isolate by PSGE, which typically indicates a point source outbreak. Based on the laboratory results and review of modes of transmission in previous outbreaks of M. abscessus, we concluded that this outbreak was likely caused by contaminated water used during pulpotomies, which introduced M. abscessus into the internal part of the tooth during irrigation and drilling. Many materials commonly used to deliver water to dental handpieces provide an ideal substrate for the attachment of bacteria and subsequently the proliferation of biofilm. So DPH issued a series of recommendations for Practice B, really emphasizing that prevention efforts should focus on eliminating potential sources of tap water contamination and assuring good adherence to general infection prevention. These recommendations included installation of point-of-use filters and replacement of pipes and tubing, and mailing outreach letters to families with a child at risk that could not be previously reached. We also requested that Practice B conduct water quality testing, sampling from different devices at different units on an alternating basis. And then when counts consistently tested at or below 200 CFUs per milliliter, then they could decrease sampling frequency to monthly. And the last thing was we recommended that they continue to use distilled water for procedures until water quality levels are consistent and practice disinfection techniques consistent with manufacturer guidelines. So Practice B responded by replacing all their plumbing and tubing leading to dental treatment areas. They purchased 2 systems for treatment of dental unit water lines, OSOPure and DentaPure, which I'm going to speak about a little bit in the next slide. They also implemented weekly shock treatment of water lines with Sterilex, which is a biocide and biofilm removal agent. So DentaPure is a cartridge that is attached to the water lines at the dental unit. As water passes through this cartridge, it then releases a small amount of the germicide iodine into the water supply. And this is considered a point of use intervention because it's installed at the dental stations where procedures are performed. Interestingly, DentaPure is actually so confident in their product that they do not recommend any water monitoring at all. Their position statement reads that when used according to label instructions, DentaPure will provide dental water with a microbial content of less than 200 CFUs per milliliter, and that DentaPure meets the standards without a testing requirement. A study that was done somewhat recently in 2013 by Molinari et al. Found that DentaPure cartridges were able to successfully reduce and achieve control of waterborne bacteria in dental water lines with CFU per milliliter counts ranging from 18,000 up to 136,000. But as you may recall from one of my previous slides, initial laboratory results from this outbreak showed microbial counts as high as 190,000. The other system is a point of entry intervention. OSOPure disinfects the municipal water that's entering the building using ultraviolet light. And it doesn't introduce any chemicals into the water supply, but rather traps the impurities through a series of filters. From left to right, the 3 blue chambers in the photo show the sediment filter, carbon block filter, and UV chamber. And on November 18, 2015, we were surprised to learn that recent water test results at Practice B indicated high microbial counts, despite the facility implementing all of the previously mentioned recommendations and interventions. So Practice B set out to further investigate and hired a team of environmental engineers to assist them. Their findings from the on-site evaluation included identification of a dead leg pipe that had an open valve upstream from the OSOPure filter that had not been replaced during previous plumbing remediation. And this is actually a picture of the dead leg valve that was later removed, and below it you can see the OSOPure unit. Practice B voluntarily closed in November of 2015 and recently reopened on January 13, 2016. They are continuing to monitor their water quality levels and using distilled water for pulpotomies. DPH has preliminarily recommended at least 3 consecutive sets of tests performed weekly from all dental units to be less than 200 CFUs per milliliter and negative for mycobacteria. This recommendation was it was a combination of 2 things. One, the American Dental Association's water quality goal for equipment to deliver unfiltered water with no more than 200 CFUs per milliliter, which is actually the same standard as for kidney dialysis machines. And second, that DentaPure guarantees to provide water under 200 CFUs per milliliter for the life of the cartridge. And for those of you who maybe were wondering, throughout this presentation, I've referenced several times that there was one patient who met our case definition, was culture confirmed, had isolates that matched by PFGE, that it was only seen at a different clinic of the same dental chain, but more than 60 miles away from Practice B. And we were really unsure how to interpret this finding, and so we consulted with CDC, and they reported that it is possible that similar practices at the other facility could have exposed the one patient to an abscessus that happens to have the same PFGE pattern, but that this is quite unusual. It's possible that this CSTE pattern may be endemic to the southeast, as this strain has previously been seen in outbreaks in North Carolina and South Carolina. And before I conclude my presentation, I also wanted to present some policy considerations that have arisen as a result of this investigation. The first one is water monitoring, required versus recommended. There currently exists no requirements for water monitoring or water quality levels. The CDC recommends that water used for non-surgical dental procedures, which includes pulpotomies, meet EPA regulatory standards for drinking water, which is less than or equal to 500 CFUs per milliliter. But that's basically all the literature says at this point. And second, should pulpotomies be considered a surgical procedure? CDC recommendations state that sterile solutions, such as saline or water, should be used as a coolant or irrigant in the performance of oral surgical procedures, but since a pulpotomy is not considered to be a surgical procedure, it's therefore not required to use sterile water. So this concludes my presentation. I'd like to thank everyone who's assisted in this outbreak investigation and production of our preliminary outbreak report. We are actually in the process of submitting an MMWR Notes from the Field article, which we hope will be published soon and be able to further contribute to the dissemination of information regarding this outbreak. Thank you.